I'll get started. So just to remind everyone of how this works. So hello, everyone, and welcome to the CMR Journal Club for July 3rd. So the topic of this week is CMR scan planning, expanding CMR through training and technology. And the reason that we picked this topic for this month is because we all know that CMR scans can be very complicated and difficult to run. And so, we can help expand the use of CMR through training technologists how to do these scans, or potentially by coupling that with technology-based solutions. And so we have at least one speaker. I'm looking for Dr. Lanza, but I don't see him at the moment. Hopefully he will join us in a bit. So we have Dr. Anazoto and Dr. Lanza to tell us about their work in training technologists and also in developing technology. And the format is just to remind everyone. So Dr. Anazoto is going to share her screen and then talk about the paper. And she has approximately 10 minutes we have for our presenters, and then there'll be about 5 minutes for questions, and then we'll move to our second presenter if the second presenter appears. If not, then we'll have a little bit of extra time, but the goal is for us to wrap up at 11:30, just to make it short and sweet. So with that, I'm going to hand over to Dr. Anazoto to talk about her work.
Thank you very much. I'm just going to share screen. My understanding is I'm going through the papers. I didn't make, as I was told, I didn't make any slide presentations, and I'm sure you guys may have read this paper, but there's sections of it that I want to highlight. And first, I do want to thank Matthias, Friedrich and his group at MUHC here in McGill, because they were very instrumental in making this happen and trying to implement this type of protocols in places where they don't do cardiac MRI, and even if they do, they don't have the skill set to do it. So I just want to start off by that. So the main aim here was essentially to try to cover one gap in MR training and education, which is actually training people on how to scan. A lot of the training initiatives that do happen in the continent are often focused on either radiologists, very short, sweet training, fly in, fly out. That's what I see it as, and not so much on implementation and actually getting those scanners being used. I think one thing that is clear is that there is an increasing number of 1.5T and higher field strength scanners that are coming in. And also there is the 0.55T Siemens systems that are now dotted around the continent. And the main challenge is how to use it. And so we developed this train-the-trainer approach because it's a way to sustain capacity in terms of training a massive amount of people, because the region, and we're talking about Africa here, has issues with retaining talent. So there is a lot of brain drain. It's not something that we could solve because it's something that the governments have to address, but one way we could do it is try to figure out a way to train people where they could at least retain a little bit of that skill set by turning them into trainers that could train other people. And so we developed this a training initiative with the approach of training a team and not an individual. Problem with training an individual is you give that person the skill set. Oftentimes they don't have the ability to knowledge translate it because they're so busy trying to implement or use that skill set. And also oftentimes because they work in isolation, that skill set may dissipate. And lastly, because, and this is something that has happened in multiple centers in Africa, is, how do I put this? There is this scarcity mentality where people tend to retain their skill and not want to translate it because they want to become relevant, or they want to be able to be employed or have that particular skill set and advance their own individual career. And that tends to happen a lot. So we decided to try to figure out a way to train a team of people that will also work together as a network, because they tend to work in isolation, and then that will be one way of retaining this ability to essentially improve MR capacity. And by improving MR capacity, the goal is obviously to increase access. The framework and how we created this curriculum is actually based on a need assessment that we did, and I'm just going to skip around a little bit here. This is based on a need assessment that we did in 2020, where we wanted to really understand the challenges when it comes to MR access. And through this framework, we're able to understand how they want to train in terms of delivery, in terms of content. We know that most of the people that we need this particular skill set are practicing and working MR personnel, so radiologists or technologists, or in this case, even physicists. And the idea is to figure out how to train them when they're practicing, and obviously also working with heavy workload. We also want to understand how they access training, especially if you're trying to bridge a knowledge gap quickly. So this was all a survey that we did back in 2020 that actually helped inform this particular curriculum. And I think the gist of the curriculum is in the paper. But one thing I wanted to point out is the approach that we took. Where's my figures? The approach that we took in trying to systematically impact a skill set and will I say a technical and also clinical skill set, and a region where oftentimes, like I mentioned, work in isolation and they obviously don't have access to training. So we wanted to first of all understand at the site-specific level what type of knowledge gaps that we have and make sure that they're actually ready to implement that knowledge. Each of the Scan With Me training programs that we do is based on a use case. So the first one we did was based on cardiac MRI. And the idea is to understand that they have the sites that we're going to train have the ability to actually implement it right away. So they must have the cardiac coils. They must have access to cases or being able to actually acquire patients. They don't have to scan yet, but they have to have that capacity to do that at least. And then we scale that up. So we did this readiness assessment that actually informed which sites we actually enrolled into the program. We created and used this teach, try, use approach. And this is an approach that was actually developed by RAD8 for implementation of PAC systems. And we essentially took that and readapted it and used it as a approach to essentially teach all the foundational skills that are required for that use case, so in this case, cardiac MRI, including MR physics, the anatomy and clinical indications that are very relevant for cardiac imaging in the region. And then we actually got them to try out all of those foundational knowledge that they've had. The foundation section of it was done self-paced, again, taking into account how the techs want to learn. It's virtual. The courses are very conceptual and sort of set up in a way where they could progressively go through and learn the foundational basic information they need for cardiac MRI. Then we had a section of the program where they given ability to try out. So we had simulators. We also had vendors come in and do live scanning to show them best practices on how to acquire cardiac MRI data. This was balanced with seminars on essentially what the radiologists are looking for, why they're even doing this particular indications. And I'll actually put them together to work and essentially adapt and implement protocols that are very specific for the type of cases they see. We taught them on how to aggregate and essentially put together case reports, because that's going to help us for future training and also gives them an ability to start to learn how to disseminate knowledge amongst themselves. And one thing that's critical in the region is the ability to do MR research. One of the main handicaps in being able to do any type of MRI research, cardiac brain, or whatever oncology, is that they actually don't have that research landscape. And some of these sequences are actually not available to them for so many reasons. And one of the reasons is because they don't actually have licenses to have this on the clinical systems. So one thing I wanted to do is to try to figure out ways of implementing advanced MRI techniques that can be implemented in the system using existing sequences, and then teach them on how to analyze some of these data sets. And so again, everything is done with the aim of putting them together as a team and then turning them into trainers right away. All of the materials that came out of this program is on the GitHub page. So anybody that didn't actually participate in the program can actually go through, I'm clicking on protocols, can actually go through the training materials and follow it week by week and be able to essentially take this course without having to participate. I mean, the one thing they'll obviously not be able to do is have that live in-person question and answer type of interaction. But other than that, we believe that anybody else in the region can actually follow this training and be able to end up with having protocols that are adapted and work well for their clinical practice. I don't know how I'm doing for time, but one thing that I wanted to stress out here, and maybe this would tie into the other speakers' talk, is that in places like resource-limited settings like Africa, most of the sites I work with, they have a very massive caseload because they have a wide catchment area of patients that they see. And when we started the program, we found out that most of them, so the amount of cardiac MRIs they do a month on average is about 1 to 5. although they have a demand that could triple that or quadruple that. And so one thing we wanted to be very specific and intentional about is to really make sure that at the end of the program, they're able to really create protocols that will allow them to be able to scan as many people as possible, but also be able to have very specific indications for the type of patient populations that they tend to see, because we're training people in Africa, in Latin America, and Southeast Asia. So cases might tend to vary from location to location. And here's an example of one site in Nigeria. So this is the site at Eyre Multi-Specialist Hospital in Lagos, Nigeria, one of the centers in Nigeria, or actually in West Africa, that does a lot of cardiac indications and intervention. They have a 1.5D Siemens system with a 6-channel body coil. And prior to the program, their typical cardiac MRI protocol was one protocol that was an hour and a half. And they did everything, they threw everything they could at the book for this particular protocol. So they could scan anything from cardiomyopathies to valve disease to everything that you can think of that's cardiac. They use one protocol, but it's an hour and a half. By the time they took the techs through the training program, and even including doing the oxygen-sensitive CMR approach, they were able to essentially have tailored protocols for the type of indications that specific center tends to see, and the longest is about 45 minutes. So essentially, we've half, and sometimes even decrease the protocol by quite a lot in terms of time, but without impacting the image quality. And image quality is quite clear because these are the type of images that we're able to produce, or they were able to produce after the program from the specific center that they have. And also we're able to essentially introduce this non-contrast enhanced method for looking at myocardial viability. And this is the oxygen-sensitive CMR, which is essentially doing carbon dioxide breath holds to induce carbon dioxide, and then essentially be able to manipulate blood flow into the myocardium. And this is very important because most centers, they don't actually have access to contrast. If they do, they use either half or quarter of the dose, so they're actually not using the contrast as well as they should, and so they actually end up producing suboptimal images. So the take-home message here is that, essentially by trying to take this approach where we are, first of all, going in and understanding the need. I'm just going to go back up here. And first of all, understanding what the local needs are, understanding how they want to train and how they want to learn, and then being able to teach them systematically using a use case as a team, because they all learn. So the assignments from when they get into when they leave is done together as a team. So the protocols that they created, which is available online for anybody to use, again, on our GitHub page, we have the protocols here. We even have instructions on how to access the protocols and use them. These protocols were created by teams that work together and worked together and actually helped each other create the protocols. And you can see the different flavor of scanners that these protocols are available for. We are scaling this back up. We're going to start the next program in a month, and this is going to focus on brain imaging. We're going to take the same approach, so the same teach trace approach, do everything in terms of brain MRI physics, give them some protocols and case simulations to learn. We're going to include ASL, so pterospin labeling, diffusion tensor imaging, resting state MRS, and we're going to actually try to get them to create dementia research protocols, clinical epilepsy protocols, clinical brain tumor imaging protocols, and then put them out there for everybody else to use. And one last thing I'm going to say is that this is actually going to tie into a dementia research study that's happening in Nigeria and Kenya. And so through them, we're going to actually create an Africa dementia imaging protocol that will be used for that study, but available for any site that want to then eventually, if they get funding or anything, be able to use that protocol and actually allow us to do multi-site studies. So I'm going to end here and take questions. I don't know if I did that in 10 minutes, but I'm happy to take any questions anybody has.
No, that was great. So we do have a couple of minutes for questions, and I believe our second speaker hasn't made it on, so I'm going to assume that he won't make it on. So we have a little bit of extra time for questions and comments that anyone has. But if Dr. Lanza is on the Zoom, please make your presence known so we know. Okay, so I'm gonna again open it up for questions. So if anyone on the Zoom wants to type something into the chat, or just unmute yourself and ask Dr. Anazoto a question, you are more than welcome to. But I think I'm actually going to kick this off. So I guess it wasn't entirely clear, and I think you described described it, but maybe I didn't quite get it. So, usually like, at least for our scanners, we get a scanner and we have to buy a separate cardiac package with like all
Yeah,
the sequences and all the special stuff on it.
yeah,
And, that's like super expensive.
yeah,
And it looks like you have protocols that aren't necessarily part of those packages. Is that correct? Or
yeah,
explain
yeah,
where
yeah,
these
yeah.
sequences came from.
Yes, yeah, that's actually a good question, and sorry I glossed over it in my 10-minute spiel. Yes, so obviously here, when you and anywhere where you when you buy a scanner, you tend to buy packages or licenses or sequences that are typical to what your site tend to do, right? If you don't do breast MRI, you most likely will not be looking for breast sequences or breast coil. Now, that's how every other region of the world works except for Africa, except for sub-Saharan Africa. So except for where Solomon is in South Africa, for example. The rest of them don't have direct access to vendors. So they go through middlemen, through third-party vendors, and that's because of regulation issues, which it'll be a whole different topic. And so for that reason, one, they don't actually know what type, how the environment is set up. So they don't know they have to buy separate licenses for cardiac. They have no idea they have to buy separate coils for doing imaging, different types, different organs, and they don't even know they need they have to buy a power injector to do contrast imaging. So we have centers, for example, that they were given essentially told to buy everything. And they didn't know they bought everything. For example, they bought a breast coil, they don't even know how to use it. But they want to do cardiac MRI, they don't have a power injector to do contrast imaging. And so for that reason, they can't even do it. We have a site that bought coil, bought the power injector, everything, but did not actually buy the license, and they can't afford the license. So there's all of these issues, and we're trying to really, and this is why the webinar, and I probably glossed through this again, this is why the webinar that Matthias did at the very end, the webinar was done to raise awareness on how and why to cardiac MR is indicated, how to get the resources you need to do those scans. This is why the vendors were really included. And this is one we're bridging that gap between vendors and the consumer. One thing that came out of this, and I'm not sure if Siemens would be pissed off at me, is that Siemens decided to to hijack one of our, I shouldn't say hijack. Siemens is not working with a couple sites in Nigeria, for example. They were very interested. These are sites that we were able to connect them with, and they're starting to do some cardiac MRI research, or I'm not sure what they're doing, but they're starting to do some cardiac MRI studies at some of these centers. And this came out of our program, same thing with Canon. So we're now trying to bridge that gap and make sure that people are getting what they need. I'm not sure if that's a long-winded answer, but
No, that helps a lot. All right, while people are thinking of their questions, so I do have another question. It seems like cardiac MR of all of the things to start with is almost the most complicated. So was there a
yes.
rationale
Yes.
behind starting with cardiac scans
Yeah.
of anything?
Yes. Yeah. Yeah. So we did that for so many reasons. One, we like to, as Africans, we really like to kill two birds with one stone. I feed two birds with one seed. And that's because if we start with something complicated, we'll be able to actually figure out the entire, so essentially stress test the whole system to design a program that can be now adapted easier to indications or use cases that are less complicated. That's one. Second is a cardiac imaging after brain, I think, should be and most likely end up being the second most important indication for cardiac for MRI in the region for two reasons. Reason number one, there's very little SPECT imaging. Number two, a lot of them are not trained on how to do ultrasound or echo very well. And cardiac MRI it's for me, it's a one-stop shop because it handles and essentially solve the problem of nuclear cardiology, which they will probably end up not having so much access to. And so I wanted to introduce this right away. Second is that stroke and cardiovascular disease, or let's say cardiovascular disease, not quite stroke, is one of the leading premature, in terms of premature deaths and morbidity in Africa, a lot of heart disease, especially even in pediatrics. And so we want to be able to also provide a way of starting to do those imaging. So cardiac became a one-stop shop in terms of developing the technique or the program, and also being able to give them and provide them immediate use of MRI for something that they probably don't know that they will need to use and how to use it, if that makes sense. So now we're going back to something that's easier. I do brain imaging, so something that's easier for me as well to wrap my head around, which is brain imaging. But we've been able to stress test the whole system with something as complicated as cardiac imaging. And Solomon is here. So I know Solomon was very instrumental in helping us out in developing the program. And Solomon is at a site where they do a lot of cardiac MRI in the region. And I don't know if Solomon wants to chime in for 5 seconds, if that's allowed.
Yeah, okay. I don't know if it's allowed, but thank you so much for the great talk. I think it really is helpful now because it's a great idea for African countries, considering the lack of access that we have to CMR. So the Scan With Me initiative is a very good one. I enjoyed it the last time we had a training, and I could see how interested most of the sites were when we were doing it. So it's an excellent work. Thank you so much for doing that.
Thank you.
Okay, we
I
have
don't
a
know if there's
question.
another question, Nicole.
Yes, there's one in the chat. Simon says, thank you for your excellent work, which I think is relevant not only to low-income regions. Did the physicians receive any training in your program or just the technologists?
Yeah, so that's a fantastic question. So when we first developed the program, we struggled between wanting to make it interdisciplinary, which is train the entire ecosystem, so the techs, the radiologists, and the cardiologists. We decided that by doing that, we're going to fall into the same trap of what actually happens right now, which is when it comes to imaging education, all the focus is on those, the clinicians, and not the techs. So we wanted to make sure to train them on how to actually acquire the images, and then follow this up with an awareness for the cardiologists on why they need to do cardiac MRI now that the sites are ready and know how to do cardiac MRI, so to drive up demand. And then I'm not sure if Mohammed, I guess Mohammed is not here and from Johns Hopkins, but he's working on with another group of people to figure out a program or develop a program to train radiologists on how to now interpret and read cardiac MRI. I think that's something that him and Matthias are going to be working on. But the idea is to do this in a tiered process where we get the sites ready to scan very well. So they're producing actually both clinically and research quality and useful images. Make sure that people are aware now that these sites are ready and can scan, so drive up demand, and then make sure that the radiologists are skilled up to actually read it. And I think that's how you get the whole system fully working and operational. I think if you put them all together, you might end up missing. Yeah.
Okay, I actually have a follow-up question to that because, have you seen that there's more referrals for CMR? Because not only do we have to have the technologists who can do it, the radiologists or cardiologists that can read it, but also, cardiologists or other physicians who are sending patients down. Like, has that increased as well?
Yeah, that's increased. I think that's what spurred the Siemens collaboration with a site in Lagos. I shouldn't be saying the places, but there is a site, one of the sites where we did training, where they have had too much demand that they're actually thinking of maybe adding another site or MRI scan, an MRI scanner to another site in another city where they are at, so they could start shuttling patients around. So yes, it is driving up demand because they now can see what MRI, at least in terms of cardiac, what MRI can do. I'm not sure if you're going to do the same with brain imaging. They're a little bit more familiar with brain imaging. The idea is to get them to know how to do it well. But things like breast MRI, cardiac MRI, where it's novel and also something that they're not familiar and aware with, it's something that we're trying to make sure that when we do that, we end up leaving the sites ready to use it and work with them to drive up demand by making sure the clinicians are aware of what and when and how to request for the imaging.
Okay, so I think, given our timing, we're just going to ask one more question and then wrap up for the day. Dr. Ferrari says, this is fantastic work. Congrats. Can you talk a bit about your approach to aid remote monitoring on physicians for level 2 and level 3 training?
Right. So the level 2, level 3 training, level 1, level 2, level 2 training, it's something that we haven't done yet because, again, like I mentioned, the first step was training the techs, getting awareness, and we're now trying to figure out. So SCMR, from my understanding, again, just bear with me, I am a neuro imaging person. So I learned cardiac a little bit during swim, which is fantastic. But we are trying to figure out how to adapt the SCMR approach in terms of training physicians and figure out how to do it. I think for remote monitoring, there are ideas, and this is still novel ideas, about trying to figure out how teleradiology is done. So there's a lot of teleradiology training that's been piloted in certain places in Africa. And this is actually done through the point of care ultrasound system setup. And with echocardiogram, with being able to do remote scanning, and we're trying to figure out how to now flip that around and actually do that for physician training or radiology training. So there's some ideas about that. It hasn't been fully finalized. I think, Victor, it would be nice to get you involved in that. I could pair you up with Mohammed and others that are sort of trying to figure out how we could make that possible. One problem with remote training, it's always a time zone between the trainer and the trainee. And the second thing is connectivity. Internet connectivity is still a big issue. So for these, we're really trying to think about ways of making the training in person. It kind of gets rid of time zone issues, and also gets rid of connectivity issues. We've had live training where people drop in and out because the network is not stable, and that's very disruptive to their learning. So we're really trying to figure out ways of being able to, again, maybe give them all the foundational information they need prior to an in-person training session that happens at sites that are really specific and ready and able to train at the site. So then we can have local training happening in Africa. So we can either bring people in, do it 1 or 3 places, and then have local training happen there. That's the idea. And again, it's still up in the air. I'm not sure if that answered the question. Yes, it will take a village. That's right. It will take a village, and that's why I'm glad. I don't know if Professor Ntusi is here, but that is right. It does take a village, and this was done. I mean, if you look at the and first of all, we couldn't put all of the authors on the paper because JCR had an author limit, and we exceeded the author limit by 10. And they were like, no. So it took a village to get this done, and it would take a village to keep getting this done in LMIC. I think this, and I'm going to end here. The idea about when people talk about health equity, global health, they always kind of make it synonymous to low research settings or low middle income. Global health is our health. It's global. We're all, like, it's everybody. And I think when we start to see that the idea of improving healthcare access, either through education, through research, or whatever that we do, comes back to us, I think that's when the entire village will work together to make sure to lend that helping hand. And I hope that anybody that's listening can understand that if you're a PhD student, Solomon was a postdoc, I started this one as a PhD student, actually. A PI, it doesn't take a lot of money, actually. We did Scan With Me with $6,000, just so you know. So it doesn't take a lot of money, well, a little bit more than 6,000 because there's travel. I would say about $15,000 because there's travel involved to get people to sites, but it doesn't take a huge amount of money to get this done. And I want to sort of employ people to understand that you can help in every way you can. So reach out to us. We're really wanting to partner with SCMR or people that do cardiac MRI to help us, especially on the physician training side. That was stuff here, I think.
That was a really great way to wrap things up. So I want to thank you especially for taking the extra time. So we're going to see if we can get Dr. Lanza to join at a later date. And I just want to put in a plug. Hopefully you guys can see my screen at this point. So we have our next journal club, which will be held on August 7th. I have shamelessly stolen Matthias's slot accidentally, but he'll be back, I promise, in a couple of weeks. So the theme of next month's journal club will be T2 star mapping, advances, and applications. So I hope that I will see you all back in a month. And for those of you who are celebrating the 4th of July holiday, have a great holiday. So thanks again, everybody. See you next month.
Thank you. Bye, everybody.
Bye.